lateral sclerosis, or ALS, disease and ocular involvement. This is by Cami Badger, Caitlin Ling, and Reagan Stone. The year is 1939, and one of the most beloved first basemen in baseball is at the height of his game, a man who, to this day, maintains the record for number of Grand Slams in a career, which is 23. In this year, this player, Lou Gehrig, caught what many have coined as his bad break. What could have possibly caused one of the best baseball players in the history of the game to walk away? In this year, the Yankees player began experiencing symptoms such as loss of strength, loss of coordination, and slipping and falling. Not good symptoms for an athlete at the highest level. A trip to the Mayo Clinic would uncover the reason for these symptoms. The trip to the Mayo Clinic would give Lou Gehrig the diagnosis he never expected: amyotrophic lateral sclerosis, or the disease today known as Lou Gehrig's disease. The diagnosis explained many of the symptoms the baseball player was experiencing as it affects the muscles. A meaning no, myo meaning muscle, and tropic meaning nourishment, no muscle nourishment. Further defining ALS. An article published by a Lancet journal defines it as a fatal neurodegenerative disorder of the motor system that affects nerve cells in the brain and spinal cord that control our voluntary muscles. You can see in the photo that as ALS kills nerve cells, muscles begin to weaken due to their innervation dying. Eventually, muscles will deteriorate to the point that they also die. An article published in Journal of Ophthalmology in 2018 defines neurodegeneration as abnormal accumulation of misfolded proteins in neural and glial elements and the ensuing phagocytosis and astrogliosis. So what causes ALS? The disease has many phenotypes. 5 to 10% of ALS has shown to be related to a mutation that may be familial. 90% of cases are sporadic. Attempts to establish the complex genetic basis has had little success for the sporadic cases of ALS.
Currently, there are no definitive tests or biomarkers present for diagnosing ALS. The presence of biomarkers would greatly refine therapeutic procedures. Neurologists rely largely on clinical criteria. A clinical hallmark of ALS is involvement of upper motor neurons or lower motor neurons, involving the brainstem and multiple spinal cord regions of innervation. Upper limb wasting is the inability to lift the arms, also called man in the barrel, and another clinical hallmark is wasting of tongue muscles, which causes difficulty with eating. ALS eventually paralyzes the muscles we use to breathe. The most common cause of death for people with ALS is respiratory failure. On average, death will occur within 3 to 5 years after symptoms begin, but there have been ALS patients to live 10 years or more. The paralysis of muscles leads to eating problems, which will then lead to malnutrition, and dementia also occurs. Currently, there is no treatment to reverse ALS. 2 medications have been approved for ALS patients. Riluzone increases life expectancy, and edavarone reduces decline in daily functioning. There are other medications to relieve the various symptoms that come with ALS, and therapies can also be used, such as breathing therapy, physical therapy, occupational therapy, speech and nutritional therapy, and psychological or social support. ALS is progressively relentless, and the prognosis is very grim. 50% of patients will die within 30 months of symptom onset, and there are risk factors for reduced survival, such as older age at the first symptom onset, early respiratory muscle dysfunction, and bulbar onset disease versus spinal onset.
Traditionally, ALS was thought to spare the visual system. In fact, since speech and motor function are impaired, they often test cognitive function using only ocular motor tests later on in the disease course. Also, eye tracking devices are commonly used for communication and to improve the quality of life of patients with ALS since their ocular motor function is often spared. However, Recent studies have shown a range of ocular motor dysfunctions in ALS patients, including saccadic impairments, pursuit abnormalities, ophthalmoplegia, nystagmus, and Bell phenomenon. It has been noted that if ocular involvement occurs, it is often later on in disease progression. In one study of cranial nerve nuclei 3 and 4 in 27 patients with ALS revealed that about a third of sporadic cases had morphologic changes similar to those in the anterior horns, demonstrating that oculomotor dysfunction might also serve as an independent marker of wider cerebral involvement in cognitive impairment in ALS. A lot of recent studies have shown more of a relative resistance rather than the fundamental sparing of the oculomotor nuclei in ALS. The first case of oculomotor dysfunction in ALS patient dates back to 1925. There was a case that started with convergent strabismus, eventually leading to complete ophthalmoplegia, and it was thought that the order of cranial motor functions in ALS might be in the reverse order of their developmental sequence, with preserved ocular motor function reflecting the fact that this is relatively old ontogenetically. Abnormal pursuits have been seen in patients with ALS. One study had 11 of 18 patients with decreased pursuit function. Saccades have also been seen to be reduced later in the disease, and it is thought that the progressive deterioration in saccadic intrusion amplitude could be a quantifiable objective marker of disease progression. There have been a few cases that have reported either a horizontal gaze-evoked nystagmus or a rotary horizontal gaze-evoked nystagmus in 2 ALS patients. And another less commonly seen effect is Bell phenomenon. There was a study that saw this reflex was altered in 15 out of 24 patients with ALS that were studied. Can the RNFL be used to measure progression in ALS? In a study done in 2015, they used OCT imaging to measure the separate retinal layers of 71 ALS patients and 20 controls. This article reviewed previous studies and stated that OCT imaging for ALS patients is sparse and heterogeneous, so they did a study of their own. In their study, they hypothesized that the examination of the single retinal layer average parafoveal thickness is suitable to detect specific retinal changes in ALS. The results showed that patients showed a significant thinning of the INL and RNFL compared to controls. So another study done in 2017 has more research with OCT correlating RNFL thickness to ALS. This study found that RNFL values in ALS patients were found to be thinner than normal for age-matched normals. The RNFL is part of the CNS, so the RNFL thinning correlates to what happens in ALS. Thinning was especially noted in the superior and nasal quadrants. Asymmetry was also noted between OD and OS, which further confirms the idea that ALS is an asymmetric disease. The study by Rohani also noted that severity of the disease correlated with lower RNFL thickness values. The study also noted that in the future, OCT may be used as a way to monitor progression of disease or document therapy response.
So what is next for ALS? With continuing studies finding more about the ocular involvement in ALS, the future could hold new treatments and possible progression tracking. Since the eye tracking devices are used to help with communication in ALS patients, it is important to check for ocular motility impairments that are now being found. The recent discovery of RNFL thinning, which it corresponds to disease progression, could also be used in the future to track the patient's progression or to show response to therapies. Here are our citations used during this presentation. Here are the group member contributions outlining which group member did which slide. Thanks for watching.